Hi, my name's Phil Lockie. I'm the surgeon involved in the Brisbane Institute of Obesity Surgery based at Brisbane Private Hospital. I'm here to talk to you about bariatric surgery and explain that it's not all about fat. Obesity is a big problem and an increasing problem. You can see from these graphs from the Australian Bureau of Statistics that we're all getting heavier year on year, both men and women. Put it another way, if you're a man in the 45 to 55 age group, about 75% of them are overweight or obese. The OECD has predicted that 2/3 of Australian adults will be overweight or obese by 2019. We're currently at 61%. From this graph you can see that obviously your mortality risk increases as your BMI increases, or put it another way, having a BMI over 40 reduces your life expectancy by 10 years, or it's the same as smoking 10 cigarettes a day. With obesity comes comorbidities, obviously diabetes, hypertension, and hyperlipidemia is the classic metabolic syndrome. You've also got increasing risk of heart disease, respiratory disease, in particular sleep apnea, but also more recently it's been recognized that asthma is associated with obesity. For women, there's menstrual irregularity and fertility issues, and psychological issues such as depression are extremely common. Again, some data from the Australian Bureau of Statistics published this year, showing that the heavier you are, the more likely you are to be diabetic, and the more likely you are to have some cardiovascular disease. Cholesterol also increases as your weight increases, but there is a genetic component to this, so often after weight loss surgery you'll see an improvement in cholesterol initially, but ultimately patients can end up back on cholesterol medication. And finally, musculoskeletal disorders increase as you get overweight. Obviously arthritis is common, and with weight loss surgery you can postpone or possibly avoid the necessity for joint replacement, in particular knee surgery. Psychological issues are very common in the overweight population. The incidence of child sexual abuse is much higher in the overweight female population, and it's something that we in the practice are very conscious of and place a lot of emphasis on with my psychologist working closely with me. For instance, we've had a patient who came to us having had multiple admissions to a psychiatric unit with depression. Essentially, she hadn't left the house for 6 months. She weighed 172 kilograms. And she sent me this email recently. I have to say she hasn't been particularly good at attending for follow-up, but she's now down to 95 kilos. Her confidence has improved. She can go out to the shops and not feel like a circus freak, and she's looking after her grandchildren, which I think is just a fantastic end result. If we look at these NHMRC guidelines, basically the old adage of someone's just fat, they need to diet and exercise has been shown not to really be effective. If you diet and exercise, on average you'll lose about 7.5 kilos in the first year, but by the second year it's down to only 3 kilos. I would suggest that if you're 140 kilos, losing 3 kilos over 2 years is really nothing. Obviously, there are some people who will have fantastic results with diet and lifestyle modification, but for the average person who wants to lose substantial amount of weight, really the only option is some form of surgery. If we now look at some of the comorbidities, as I've stated previously, as you get heavier, your risk of diabetes increases. 60 to 70% of type 2 diabetics are overweight or obese, and we know that if we can lose 30% of our excess weight, we can induce remission of diabetes. A recent study from Paul O'Brien in Melbourne, looking at lap band patients, demonstrated a 73% remission of type 2 diabetes following surgery, as compared to 13% with best medical treatment. Studies from the United States have shown that the earlier patients are referred for bariatric surgery, the better the long-term results. So they do best if we get them when they're starting on their diet for diabetes, as opposed to when they're on tablets, and the ones on tablets do better than the ones who've been on insulin. Having said that, we have operated on patients who are on insulin for type 2 diabetes, and whilst they tend not to get off their insulin, they can certainly have much better control. So from my point of view, I would like to see a lot more diabetics referred a lot quicker. Here's a study from the United States from 1995. So that is more than 15 years ago, suggesting that type 2 diabetes should be treated with bariatric surgery. So my question is, where are they, and why are we not seeing them? Cardiovascular disease, as we've previously pointed out, is linked to weight. Your risk of dying from cardiovascular disease is 5 times higher if you're morbidly obese. Interestingly, long-standing obesity is a risk factor for heart failure, and the long-term survival from heart failure is as bad as many cancers. And it's been shown that the long-term reduction in mortality seen following bariatric surgery is mainly related to cardiovascular and cancer deaths. Respiratory function, obstructive sleep apnea, OSA, is very common in the morbidly obese patients. We spend a lot of effort looking for occult OSA, and we know that if these patients can lose a relatively small amount of their excess weight, they can have resolution in their obstructive sleep apnea. I've had one patient diagnosed with severe OSA pre-operatively, who came back at 6 weeks post-op. He had lost about 25% of his excess weight, and a repeat sleep study showed that his OSA had largely resolved. As I've said previously, there's some interesting suggestion that asthma can also be related to obesity, and I've certainly had a couple of patients whose asthma had disappeared after their weight loss surgery. Another area that's been attracting interest recently is the link between cancer and obesity. Studies from the United States have suggested just over 3% of all new cancers are linked to obesity. There are some specific cancers that are clearly linked to obesity. Colon cancer, particularly in men, breast cancer and endometrial cancer in women. You're 5 times more likely to develop endometrial cancer in a postmenopausal woman if you are morbidly obese. And there's also links to renal and esophageal cancer. So about 14% of cancer deaths in men are linked to obesity, and 20% in women. Interestingly, if men lose weight, their risk doesn't decrease as substantially as women, and that's probably a reflection of the reduction in risk of breast cancer seen and endometrial cancer seen in the female group. For women, obesity is linked obviously to fertility and menstruation. About half of obese women have irregular periods. They're much more likely not to ovulate, and there's a clear link to polycystic ovarian syndrome. And again, if we can get them to lose as little as 5%, of their excess weight, they can start to ovulate. And one of the side effects, so to speak, of weight loss surgery is increased fertility, and I've certainly had several patients who have become pregnant after their weight loss surgery and has successful pregnancies. With pregnancy, obesity increases your risk of hypertension, gestational diabetes, preeclampsia, postpartum hemorrhage, and there's a risk of increased risk of congenital abnormalities, although that is fairly small. Interestingly, there is now the suggestion that if you're obese and become pregnant, that you are predisposing your child to being an obese adolescent and obesity in later life. So we're running the risk that we're setting up a future generation to have problems with obesity by not acting on the levels of obesity that we have in society at the moment. So as you can see from this slide, weight loss surgery can produce significant improvements in a lot of these comorbidities, and we're not talking about 5, 10, 20%, we're talking about figures in the 70 to 80 to 90% improvement, which I think is a clear indication that we should be performing more bariatric surgery. So when people say to me, oh, you're a bariatric surgeon, you make people thin, I don't make people thin, I make people well. We're treating the comorbidities, we're not treating the fat. With my practice, I have an integrated approach. I very much believe that the surgery is very much the beginning of the whole process, and we have to provide detailed psychological support as well as dietary support and exercise. So that's why I have my own psychologist who specializes in bariatric surgeons and is currently undertaking a PhD looking at post-op bariatric patients. I have a very good exercise physiologist and a dietitian with a very long experience with bariatric surgery. We have a free patient support group that meets once a month that my psychologist runs for us. I'm very much a believer in patients who are having bariatric surgery or considering bariatric surgery should talk to people who've been there and done it. I can tell you what it's supposed to be like, but I think it's much better if a patient can talk to somebody who's been in their shoes and can show them what it's really like. To my knowledge, we're the only practice in Queensland that operates such a carefully integrated approach. This is a presentation that was made at one of the American meetings back in 2008. They looked at all of the bariatric practices in France and demonstrated that the differences in complication rates and weight loss was not about what happened in the operating theatre. It was what happened in preparing the patients for surgery and looking after them afterwards. The surgery in itself is a relatively straightforward part of the whole procedure. So in terms of weight loss, we can offer a tailored approach. The sleeve gastrectomy is my operation of choice, simply because we're just getting such good results with it. We do a small number of bands, but not a lot. And I also do some gastric bypass. They're all done laparoscopically. The gastric bypass I tend to favour for diabetics and also as a conversion procedure for patients who have had gastric band surgery or lap band surgery and they're not happy. I can go from a lap band to a bypass in one operation, whereas if you want to go from a lap band to a sleeve gastrectomy, it has to be done as a two-stage procedure over about 3 or 4 months. So the band, Australia is the banding capital of the world. We do more bands than anybody else. It's certainly the simplest and the safest procedure. In terms of excess weight loss, it's around about 50% in the long term. but it has a reoperation rate of between 25 and 45%. It's falling out of favour in Europe, and certainly hasn't been embraced perhaps as much as had been anticipated in the United States. Sleeve gastrectomy is the modern version of stomach stapling. It's become very, very popular over the last few years. We've done over 150 now. It's keyhole surgery, it's a couple of days in hospital, and we're achieving about 75% excess weight loss at 6 months. And the studies from Spain would suggest if your BMI is between 40 and 45, you're highly likely to achieve your normal weight within about 2 years, and certainly we have increasing number of patients who are achieving that. The gastric bypass, it's the most common procedure performed in the United States. It's been around for 40 years. It can be done laparoscopically, although it's technically the most difficult. It has excellent long-term results, and it's particularly beneficial for diabetics. With the diabetics, they can get rapid improvement in their diabetes within a matter of weeks before they've lost substantial weight. These are some of my preliminary weight loss results. We haven't looked at the patients for some time, so that's why the graphs start to go awry at about 10 months. The main problem is people lose 75% of their excess weight, and they feel fine and they want to get on with their lives, and they're not so inclined to come back for a review. These are some of my patients. This young lady came to me with diabetes and metabolic syndrome, weighing 97 kilograms. 12 months later, after her bypass, she's down to 70 kilograms and off all of her diabetic medication. Andrew, your more typical patient, presenting with 145 kilos, BMI of 50, hypertension, hyperlipidemia. Within 16 weeks, he had come down to BMI of 34. He's now under 100 kilos and off all of his medication. Another sleeve patient. This is one of my first sleeve patients who had her surgery and then went off to London to work, and she remains in London and is basically having the time of her life. Another patient who's had an excellent result and has avoided knee replacements. Another young lady who's done very well. And one of my first patients whose only regret was not doing it sooner. So hopefully you'll find this talk interesting, and I would like to emphasize that weight loss surgery is not about treating fat, it's about treating comorbidities. Thank you.